This short video will serve as an introduction to the enhancing patient recovery protocols described farther down in this website. The immediate challenge in improving surgical care is not in creating new techniques or new technologies to improve surgical care, but rather to apply what we already know to every patient having surgery. So we need to do that in the preoperative period, the intraoperative period, and the postoperative period so that care is standardized and outcomes are standardized. A patient having an operation in Michigan should have the same outcome as a patient having an operation in New Mexico, given that the patient has the exact same risk factors. Currently, our education is different for our patients, our preoperative care is different, our intraoperative care is variable, and our postoperative care is variable. And then people are surprised that outcomes are variable. So our goal with this project is to standardize care insofar as much as we can and improve outcomes. In the preoperative time period, we look at patients from the time of boarding of surgery until their arrival in the preoperative holding area. We focus on prehabilitation or buffing up of patients before surgery and education. Education involves healthcare literacy, which means that we're telling patients the right thing in the right language so that it is retained by our patients. We're managing the patient's expectations appropriately so they're not told, oh, you'll have no pain after this operation, you're going to feel great, but rather they're told appropriately how much pain they're going to have on which day. We'll focus on nutritional optimization, prehabilitation with exercise, as well as mental health assessments, and most of this will be done with preoperative education classes that will become mandatory for our colorectal surgery patients. I have smoking cessation in parentheses here because most enhanced recovery protocols do include smoking cessation. The problem with that is that patients who stop smoking within 2 to 3 weeks of surgery do not have improved outcomes, and so if you really want to see the true benefits of smoking cessation, you need to do it at least 3 to 4 weeks preoperatively, which we typically don't have to work with in our patient set. Intraoperatively, we talk about patient care from the time that the patient arrives in the preoperative holding area until the patient is discharged to the ward. We know about skip measures, which are federally mandated, centrally measured measures of intraoperative care, and we're all very good at making sure that our antibiotics are documented well and glucose is treated and so forth. But also avoidance of NG tubes in patients, giving the right bowel prep to the right patients, managing our intraoperative fluids appropriately, using pre-medications in the right patients and avoiding them in the wrong patients, using short-acting anesthetics to improve recovery, and avoiding postoperative vomiting and using multimodal analgesics to improve pain care. In the postoperative period, or the enhanced recovery period, again, we're talking about the time period from when the patient arrives in the ward until they return to their level of baseline function. So this actually carries the patients beyond their hospital discharge time. We should be very interested in maximizing the use of multimodal analgesia and reducing the amount of opioids that we use, which will in turn improve gut motility, improve our ability to feed patients early, which is definitely linked to hospital length of stay, mobilizing patients early, getting them walking and quantifying how much we're walking them, removing Foley and nasogastric tubes early, and then again, managing patient expectations and teaching them what to expect in the immediate and longer-term postoperative period. The mission with all of these, the preoperative, intraoperative, and postoperative optimization programs, is to maximize the use of evidence-based medicine, and I know we talk a lot about evidence-based medicine, but we don't do a great job of implementing it. We want to optimize patient education as described, and we want to really standardize our care. And by doing this, our goals, we hope, are to improve quality, safety, and outcomes, improve patient satisfaction, decrease variability, and decrease cost. And we are currently measuring all of these things as part of this program, and we will continue to monitor it, with the goal being that we will have a dashboard, which is already in place, that will show a change following program implementation. So putting it all together, you have a patient who has the typical level of functional ability. Up here in the top dotted line is their baseline level of functional ability. The bottom dotted line is the minimum level of functional ability that they need to get by. You tell the patient, hey, you need colon surgery, you got cancer. They get depressed, they sit on their couch, they stop eating, and their level of functional ability goes down. They have surgery, which really drops their level of function, and they have a slow recovery and they may never reach their baseline level of function again. By instituting prehabilitation and enhanced recovery protocols, the goal is to, again, buff patients up before surgery, decrease the size of the surgical insult, and then speed recovery afterwards so patients get to and perhaps even exceed their baseline level of function. Now, many international institutions have instituted these. The country of England has instituted enhanced recovery protocols for the last decade and shown outstanding results. And Duke University is the first in the United States to really do this in a well-organized, standard fashion. They have chosen to focus on these measures for their pre, intra, and postoperative care based on World Journal of Surgery guidelines, and we have done the same, which we will show in the next slide. The other part of an enhanced recovery project is to have a good project team in place with the appropriate experts to consult on each of these different aspects of care. We have anesthesia, nursing, research, surgery, administration, quality, marketing, physical therapy, service, pharmacy, library, and nutrition all involved in our current team, and we have monthly meetings where we decide upon best practices and best ways of implementing these practices. And again, these are the practices that we have chosen to focus on at Beaumont. In the preoperative period, you can see nutritional optimization, strength and conditioning, appropriate use of pre-medications, antibiotic bowel preps. Intraoperatively, you can see goal-directed fluid therapy and anesthetic optimization, and postoperatively, early feeding and early mobilization. Nausea and vomiting control span intra and post-op, as do early removal of tubes and catheters in the bladder bundle, and then multimodal analgesia, glycemic control, and then education and expectation management span all 3 time periods. We have created videos for each of these 13 interventions down below on this website. They are all 3 to 4 minutes or less. They all discuss evidence-based medicine and recommendations. So 2 slides, simple discussion, what we've learned from the evidence, and how we're going to implement that in our enhanced recovery protocol. This is not the type of program where you start the program and then you never follow up on it. We will be enrolling patients, implementing the protocols, collecting our data, but then evaluating our outcomes and evaluating our data so that we can update our protocols as we need to and then continue to go around and around the circle. Our goal is to continually improve patient care, move forward beyond colorectal surgery patients, and make this a system-wide, surgery-wide protocol. For more information, feel free to access the videos and the evidence-based literature found below, or contact me, Rebecca Kelly, who's our project manager, Dan Salvasi, or Carol Schmidt. We'd be happy to help you. Thank you very much for your time, and enjoy the videos down below.